Hello, this is Mohamed from Year 3. I will be explaining today the pathology lecture of the heart valves. In general, when we talk about the pathology of the heart valve, either we might talk about stenosis or regurgitation. Stenosis happened maybe to calcification like in old ages or rheumatic heart fever, talk about especially the mitral valve. Regurgitation happened, maybe here we have either problem in the valve itself like mitral valve prolapse or sometime ischemic heart diseases that is affecting the papillary muscle and all of this. Sometime it's also functional. It is the structure around the valve which dilate, not the valve itself. Either, for example, when we talk about the pulmonary and aortic valve, if their artery dilated, the valve will dilate with them. The mitral valve, for example, if the ventricle dilate, it will dilate with it. So it is not related to the valve itself, it's a problem with the surrounding structure. So in general, when we talk about now we talk about the pathology, we'll start with the aortic stenosis, which is the most common pathology here and the most dangerous one as well. How it happened, either in very old age, because here there is multiple wear and tear happening all over the years of the all over his life. So at a later age, 70s or 80s, he will start to have calcification. That's like it's a normal aging process. Or a congenital bicuspid valve. This will show earlier, like in 40s or even 50s. The aortic stenosis, unlike or aortic calcification, unlike, for example, the mitral one, which we'll talk about later, they called it happened in the cusps, not in the annulus, and as you can see, it is hidden. So I can't differentiate the color between the calcium inside the valve and the normal endothelial color of the valve itself. That's why we call it a hidden. So that's for morphology, and it especially affect the outflow site. It is very dangerous because it is the most dangerous valve disease. In most of cases, it lead to death if we left it untreated. What will happen? Let's go to the clinical feature before we talk about the treatment and the microscopic. What will happen in general, that the blood will suffer going out to the aorta. So the left ventricle must start to accommodate this and do hypertrophy, because we need more muscle power now. But we have a problem. Okay, the left ventricle will go to hypertrophy to increase the muscle power, but the blood supply will not. Like here, the muscle will increase, but blood supply will not. So this will make a problem to the heart, starting by first an angina. If it is appear, we know here that we enter to something called the classic triad, if you remember them. It's a triangle. Here we have was angina, here and we were having syncope and heart failure. Heart failure is the least and most dangerous consequences, because there is no blood supply enough to accommodate the muscle power that the heart is using. So most of the time, if the signs of heart failure came, the patient have 2 years before death if we left it untreated. What we need to do, most of the time it is surgery to prevent mortality. As we said, if we left it, patient could die very easily. Now, on the other side, when we talk about mitral stenosis in general, we think about rheumatic heart disease, but there is something called mitral annular calcification, which is not that common. It appeared lately. It was not that common in the past, but it is like a very rare type of valvular heart disease, which here there is a calcification in the mitral valve, especially if the woman is, especially in women above 60 years of old. What will happen here, that we will have an annular, unlike the one on the aortic which was in the cusp. And here I can differentiate easily the color. I can see the endothelial here very clear, and here it's very prominent. It's not hidden, or it is not some endothelial. As like a calcification, it is not that dangerous at all. But what it is dangerous, I mean, like it is not dangerous, it will not affect the valve function, but it is dangerous because this vegetation might lead to maybe thrombus stuck here, then it might go out as a stroke, or increase the risk of endocarditis, because this area is preferred area for bacteria to hide in and do vegetations on it. So what we need to do for the patient, first we might do surgery to remove the nodules. We might give him sometimes some medication to lower the risk of getting the stroke, but most of the time we must remove the nodules. Now for mitral stenosis, beside the annular calcification, which is rare and happened in age, here rheumatic heart disease is the most common one. What happened, because of recurrent acute rheumatic fever infections, if the patient was not, for example, taking his prophylaxis well or whatever, or he having multiple infections without control, he will have the chronic part of the rheumatic fever called rheumatic heart disease. What will happen? The mitral valve will start to thicken and will have a commissural fusion. Also, the chordae tendineae will start to be thickened and it will be shortened. That will make a very characteristic feature of the mitral valve. We call it like when you want to put a button in a hole, for example. Now, what we need to do here, we need to do anticoagulation. We will mention why, and surgical replacement of the valve. Why we need like anticoagulants here? The special thing that happened, okay, there is now stenosis here, blood can't flow out of the chamber. What will happen? Blood will start accumulate in the left atrium. This will make us two problems. Problem in the lung, where the blood comes from, and problem in the left atrium itself. If like now the blood can't go, so it will start to accumulate here. So now new blood can't come from the lung. What will happen to the lung? Congestion. Blood will stay there, and it will make for us pulmonary hypertension. What will happen if now there is pulmonary hypertension? We will have right ventricle hypertrophy. Why? Because the right side is what pump to the lung. If the lung is obstructed and can't pump and can't give it blood to the left atrium, what will happen? Blood will stay here, and he will start to feel to have resistance against the right side, so we will have hypertrophy. This is for the pulmonary hypertension side. For the left atrium, what will happen in it? Because blood start pooling there, but we will suffering from is dilation in the wall of the left atrium. That might, like, do you remember the SA node and the electrical pathway of the heart? That might disturb and cut these electrical wires, if you want to say, between the left atrium and the right atrium, which here we have the SA node. So what will happen? The left atrium will start to like beat on its own. Every part of it will start to beat on its own. What we call the atrial fibrillation, AF. We need, like you'll study it later, if the patient, atrial fibrillation is not dangerous as an arrhythmia, but to protect the patient, we should give him anticoagulant because he's having high risk of stroke. That's why here we need. Now for rheumatic fever. Rheumatic fever it might, as we said, come as acute rheumatic fever, which is here an autoimmune disease hypersensitivity, type 3 طبعا, happening because of molecule mimicry, or if it was left untreated, patient is not taking prophylaxis, it will become chronic, and the patient might suffer then from mitral stenosis. The chronic rheumatic fever, the other name of it, rheumatic heart disease. Okay, in the acute rheumatic fever, for the chronic rheumatic fever, we have discussed it here. Now for the acute one, how it happened? The acute one happened because of, as we said, autoimmune hypersensitivity type 3, especially to group A streptococci infection after a pharyngitis. Usually it will happen because it will happen after 1 or 2 weeks after a throat infection. You will ask the parents, because most of them the patient here is like in the pediatric age, we'll ask him about the history. The parents might tell you, oh, he was having a throat infection. So I know that the patient could now suffer from acute rheumatic fever. What acute rheumatic fever do actually? We say it's a systematic disease. As we said, it is affecting or mimicking something called molecular mimicry, which is when something inside a pathogen, in our case the streptococci, there is a antigen on it is very similar to some of our self antigen. So our body will by mistake come and attack our cells, especially, for example, nervous system, heart, joint, skin, and multiple other organ. So here what we need to do, or how we diagnose a rheumatic fever, by Jones criteria. Jones first, which is the polyarthritis, but here it is special because migrating polyarthritis. It is not like the rheumatoid or osteoarthritis. Here it will start at, for example, somewhere like the hand, then it will go to the, suddenly it will start like not to go in order, elbow, suddenly knee, suddenly hip. It is not following a symmetrical order, for example. Then we have a pancreatitis affecting all the 3 layers of the heart, nodules, which we'll mention, erythema marginatum, and Sydenham chorea. Sydenham chorea, when you say it, you will never forget it. Like the patient you will see him start to dance. These five signs are what we call the 5 major criteria for diagnosis of rheumatic fever. There is a minor one. I think it was mentioned more in the micro lecture. So the only one, like you need here 2 major or 1 major, 2 minor. The only one that is happening, like if it's happened, you diagnose like immediately rheumatic fever, is Sydenham chorea. It's a pathognomonic. Okay, that about how we diagnose it. What like now it do to the heart? As we say, it do pancreatitis, so affecting all the 3 layers of the heart. Epicarditis, for example, endocarditis, and myocarditis. In epicarditis, you'll hear friction rub. It's like the bread and butter appearance. In endocarditis, will start to have some like fibronoid necrosis, very small lesions inside the valve itself, especially between the junction of the valve and its chorda tendini. That's how you will see the necrosis of in the endocardium. But there is a pathognomonic here, which is ash of bodies, which when we see it, we know it's rheumatic fever. It appears especially in the myocardium, but in when we take a sample. But in general, it can appear in all the layer of the heart, so endocardium, pericarditis, and all of this. But most of the sample, we take them from the myocardium. What is ash of body? So for ash of body, it having these 3. Especially, we said we can see it in the 3 layer. The pathognomonic, which is called anticow, or the caterpillar appearance cell. It is once we say it, we know it's a rheumatic fever. We must have some lymphocyte infiltration and fibrinode necrosis, especially here if we are in the endocardium, as you remember. Scarring might appearance and other complication like, as we said, mitral stenosis. What we need to do now, give some antibiotics for acute attack to prevent it from going into long-term, to prevent it from go into a long rheumatic fever or chronic rheumatic heart disease. Now we'll talk about the infective endocarditis. It having two parts, acute and subacute. They differ in the severity and their microorganism. The acute one having more high of mortality. It is a very type of severe infection. Maybe patient can die within days, sometime week. The one that they cause it is group strep, staph aureus, especially if the patient is drug abuser, pneumococcus bacteria. For the subacute, which is having low mortality rate, low violence, maybe sometime fever here is absent, and the infection here can't extend into week. The most one cause is the hack group and the Veridins. If you remember the Veridins, which wasn't like giving risk for endocarditis after, for example, a dental procedure. Also, we have a microorganism that can make infective endocarditis, but the patient must have a prosthetic valve, which is the staph epidermidis. Do you remember this biofilm ability of them? What are the risk factors? As we said, the patient might have be alcoholic or IV drug abuser. He might be immunodeficiency. Some organism now will start to affect the valve because he's not having a very strong immune system. Might be a problem in the valve itself. Like if the patient having, for example, damage to the valve before, that increase the incidence of getting infective endocarditis, especially in the subacute type. Acute type might affect the normal one and the abnormals, like if the patient do have injury, for example, to the valve, as we said. But here, most time it's affecting the abnormal valves. What will happen here at the microbial level? We'll start to see colonization and invasion of the valve. The valve here will start to be febrile and will start to have bulky vegetation. That's why here we are risking a regurgitation, especially in the mitral valve. What we need to do, we need to give prolonged antibiotics because the endocarditis might come back to the patient. Possible if the damage was too severe, we might do surgery to the patient. Now, as you said, what we'll be seeing, the microorganism and it's in why we emphasize on vegetation here. These microorganisms take the vegetation as place to hide from the antibiotic. That's why it is so important to imagine how these are protecting the bacteria itself. But these vegetation will cause coagulation on them. That's why people with infective endocarditis might have something called septic emboli. Septic means infectious, emboli means the thrombus was on the valve will start to go away and go, for example, to the coronary artery of the heart or the brain, causing stroke. That's why it is so important to manage the patient so he don't get these type of consequences. Now, what will, as we said, fever is the most abundant one. Will have embolic feature. If you remember from your OSCE, the hemorrhage that was happening on the palm, we call it ossular nodes, which is the painful one. And we have splinter hemorrhages. These come from the emboli. The rest might come from a something called immune reaction, immune antibody complexes. If you remember, the Roth spot on the eye, the Janeway lesion, and glomerulonephritis. So all of these might be or might be a consequences of infective endocarditis. Now for the mitral valve prolapse, here we are risking for regurgitation. Still, the valve can hold the blood and do its function, but it prolapsing and going again or backward into the left atrium. It is not that problematic. Most of the time, it's asymptomatic, except in severe cases like it might start to cause arrhythmias. So we need to manage then the situation. What happened, or in what cases we see this mitral valve prolapse? In most cases, in something called megasomatous degeneration. It is a problem with type 6 of collagen. It's either primary, which is here women have more chance of getting it for unknown reason, and reason, and secondary. Here, women and men are equally are equal in chance, and here it might for underlying cause like IHD, which is ischemic heart disease, for example. There is a ischemia to the papillary muscle, so now there is kind of weakening and prolapsing. So type 6 collagen maxomatous degeneration go for kind of primary, secondary, or more of ischemic heart disease and all of this. But what I will be seeing is enlarged type of floppy, thickened, and rubbery leaflets. That's prolapsing going into like unneeded prolapsing leaflet in the left atrium during systole. That's why it have something called mid systolic click, which you should remember. It's one of its characteristic. What we need to do here is a surgery for severe cases and managing the arrhythmia. As we said, it might cause in severe cases type of arrhythmia. It happened with anxiety as well. Patient has start to feel its symptom and its arrhythmia start to get worse. So that's why we need to manage it. What will happen if we if we left it untreated? And then we will have regurgitation because, as you said, there is weakening. So if we are not taking most time we actually like discover it by accident, but if then we didn't take action, we might have a regurgitation, which is a multilateral regurgitation, the holosystolic murmur, if you remember. What I will be showing on the microscopic feature: thickening of the fibrosa, the outer layer, and some collagen attenuation inside the spongiosa. For the last one, the NBTE, non-bacterial thrombotic endocarditis, which is usually happened with like cancer patient and sepsis most of time. The doctor he does not focus so much on this. Actually happened also with sometime with patients who have like problem with their coagulations and all of this. What the characteristic or what differentiated from the infective endocarditis, we'll only see a like bland thrombus, no inflammation, no bacteria. This vegetation does not have like a microorganism at all. So we are not afraid of infection, but what we are afraid of is the patient might have some embolic complication. That's why we must be cautious. And often we say it's asymptomatic, we discovered by accident, and it can cause emboli.
Hello, my name is Dhuha. I'm going to be explaining the infective endocarditis lectures, the micro and the pharma. There are parts from other lectures that are included in both of these lectures, such as pathology. I'm not going to be going over that because one of my other colleagues is going to explain the pathology aspects and the pathology lecture. So all I'm gonna do is go over the important parts over the micro and the pharma lectures, and I'm gonna tell you what to focus on, what's most important, and what you need to know for the exam. So we'll start by infective endocarditis. There are risks to developing infective endocarditis. The top most one is having a prosthetic valve, which you need to know, the top number one, okay? Then comes rheumatic heart disease. The valves that are most commonly affected, we have the mitral valve, number one, and then comes the aortic valve. In case of patients that are known for injection drug use, they're going to have the tricuspid valve, and most likely is going to be affected or involved. So let's start with going over the bacteria that can cause infective endocarditis. So first of all, we have staphylococci, we have Staph aureus and Staph epidermidis. For Staph aureus, it's catalase positive, coagulase positive. You have to know these for the exam in case the question comes and gives you the reactions or the bacteria, what does it do, and like specific text, what agar does it grow on, and all of that. You have to know these because you are supposed to know what pathogen or microorganism that caused it. So you have to know it's catalase positive and coagulase positive as well. It grows on native valves, so patient first time coming and their native valve, they don't have like previous issues. It's most likely Staph aureus. And it causes acute endocarditis, so they're gonna have a high fever and systemic toxicity, and if it goes uncontrolled, it can cause death. We have MRSA, or methicillin resistant Staph aureus. They have increased incidences, and they're hard to treat with the regular antibiotics. So what we do is we give them vancomycin or daptomycin, which is the drug of choice for MRSA. For Staphylococcus epidermidis, you have to know that the virulence for it is biofilm, or creating a slime layer. It comes with prosthetic valve endocarditis, such as patients coming to the hospital and like getting the surgery of prosthetic valve, and then they're going to get infective endocarditis within like 2 months of getting the prosthetic valve. It can also enter the body through catheters or any external devices that enter the body. Any history of injection drug use, you think of the tricuspid valve, and you think of Staph aureus here. Okay. For the streptococci, they're also a common cause of infective endocarditis. They're found in the oral cavity. So when you brush your teeth, you're introducing bacteria into your bloodstream by these minor cuts and scratches into the gums. We have bacteria called strep viridans. They're alpha hemolytic streptococci. We have strep mitis, sanguis, and oralis. The most important one is S. bovis, which is associated with colon carcinoma. Let's say you're working, you're a doctor, and a 63-year-old patient whom was diagnosed with colon carcinoma comes in and is diagnosed with infective endocarditis. What is the most probable microorganism you would suspect? S. bovis. This is very important. For the HACCP group, they're gram-negative, they're fastidious, they're hard to grow on, they're hard to culture, basically, and they cause infective endocarditis and damaged valves or any underlying heart diseases, and they're sensitive to penicillin. So any regimen that includes penicillin should clear out the infective endocarditis if the patient has infective endocarditis due to these microorganisms, the HACCP group. For Pseudomonas aeruginosa, it's also found in IV drug abusers. We mentioned Staph aureus, but for Staph aureus, it's more common. So think of IV drug abuse, tricuspid, most common is Staph aureus. But if, let's say, it doesn't come along with Staph aureus, like the bacteria is not catalase positive or coagulase positive, you're going to think of Pseudomonas aeruginosa. And chosen the tricuspid, as we mentioned. For Bartonella, they're culture negative pathogens, so they don't show on culture. You culture the patient, they don't show, so just think of Bartonella. Let's say a patient comes in to the hospital and they have infective endocarditis. You're suspecting it's infective endocarditis. Clinically, they show signs, But when you culture the patient's blood, there is nothing, basically. So it's most likely Bartonella. We have native valve endocarditis and prosthetic valve endocarditis. For native valve, there are acute forms. You have to know how it shows on the patient, because these signs might come in the exam and they might signal to you what microorganism might be the cause. So for acute, we have high fever, systemic toxicity, and death. We mentioned Staph aureus causes acute endocarditis. For the subacute, it's in a setting of prior valvular disease. So basically, the patient has to have previous diseases of the heart, and it takes slower course, low-grade fever. They're more like night sweats rather than high fever and systemic toxicity. And they're usually caused by the streptococci or strep viridans, which we mentioned is alpha hemolytic. So let's say a question comes and it says, a patient who has been showing low-grade fever for the past few days, night sweats, and upon culture, the bacteria is alpha hemolytic, streptococci, most likely is going to be strep viridans, okay? Or any of these bacteria that are mentioned here. For prosthetic valve endocarditis, within 2 months, it's very early. It's like early prosthetic valve. And after 2 months, it's late prosthetic valve endocarditis. For early, they're usually hospital-acquired and are caused by staph epidermidis, which we mentioned is caused by prosthetic valve endocarditis for the early PVE. After 2 months, it's late prosthetic valve endocarditis, and it's most likely community-acquired, are either due to enterococci and or streptococci. So either S. bovis, viridans, or the enterococci, which we are going to discuss later on. For infective endocarditis in IV drug users, it's the most common cause is Staph aureus, and then comes Pseudomonas. But most common is Staph aureus. Just think of that for now. And it's usually involving the tricuspid valve. For infective endocarditis in the IV drug users, just think of tricuspid valve. Okay. For the diagnosis of infective endocarditis, of course, you have to diagnose based on clinical presentations and Duke's criteria. For Duke's criteria, to diagnose a patient with infective endocarditis, you either need 2 major, or if you can't find 2 major signs on the patient, you can use 1 major and 2 minor. And please remember this because this is very important. 2 major or 1 major and 2 minor to definitely diagnose a patient with infective endocarditis. But the most definite and gold standard way to diagnose a patient with infective endocarditis is by blood cultures. Blood cultures is the gold standard. Please remember this part. This is really important. Then comes the echocardiography. The most sensitive one is the transesophageal. It has 80 to 95% sensitivity. So it's clearer to see, and it's more sensitive to show you the vegetations on the valves. For the blood cultures, you need 3 at least. 3 blood cultures because the bacteremia is continuous. So no matter what time you take blood cultures from the patient, that doesn't really matter because the bacteria is going to be still flowing in their blood the entire time. So the more blood cultures you take, the more positivity of knowing what microorganism might cause the infective endocarditis in this patient. Timing is not important, but the volume is. You need at least 40 ml in a single sample or 20 ml each 2 samples. And the blood culture bottles contain diluents. These diluents, of course, they dilute the blood, and they contain nutrients, and also they contain antiplatelets, so they could stop the blood from thrombosing or coagulating, and they allow the bacteria with the nutrients that they contain, they allow the bacteria to grow and thrive. So we can culture it later on. For pericarditis, it's inflammation of the pericardium and can be acute, recurrent, or chronic. It can be viral. self-limiting disease, usually with viral pericarditis, but bacterial pericarditis, they're less common. But for bacterial, it's best to give antibiotics. For myocarditis, can show arrhythmias, which is an important sign. And they're most commonly affecting the children. And the most common viral cause of myocarditis is the Coxsackie virus. This is all that you need to know. Just Coxsackie virus, myocarditis in children. For enterococci, which we mentioned earlier, they're gram-positive, they colonize the gastrointestinal tract, and they grow in the presence of high concentrations of sodium chloride and bile salts. They're catalase negative, PYR positive, resistant to bile and optogen. So let's say a question comes in the exam, or a patient comes to you in real life, and when you culture their blood, you see bacteria that grows in high sodium chloride or bile salts. It's catalase negative, PYR positive, it's resistant to bile and optogen. You're going to suspect that this is enterococci. And it comes from the patient's bacterial flora. It can cause UTIs, peritonitis, wound infections, and endocarditis. They're very common diseases or conditions that are caused by enterococci. Let's say a patient comes in with UTI and then develops infective endocarditis. Most probable cause is enterococci, but they're also going to give you more details on the bacteria itself, like what's catalase, how does it catalyze, is it catalase positive or is it catalase negative? Does it grow on bile salts or not? Is it resistant to optogen or is it not? And all of that. So it makes you able to understand the bacteria more and know what is the probable microorganism. For enterococci, they're showing resistance, and it's becoming very common. So they're also showing vancomycin resistance. So what is the drug of choice in this case is linezolid for vancomycin resistant enterococci. And the regimen also consists of aminoglycoside and cell wall antibiotic for better bactericidal effects. For the pharma part, we have empirical therapy. The empirical therapy is you knowing that this patient has infective endocarditis, but you still don't know what exact microorganism that caused it, okay? We have prophylaxis. You should give prophylaxis for 3 groups. Okay, for empirical therapy, it should cover a wide spectrum of microorganisms. So the best drug of choice in this case is using IV vancomycin for initial therapy. For prophylaxis is preventing the patient from getting infective endocarditis. There are 3 main cases that you should give the patient prophylaxis for. Is when they have foreign material in the heart, any previous diagnosis of infective endocarditis, and cyanotic congenital heart disease. Cyanotic congenital heart disease, just like tetralogy of Fallot, which it allows the blood to regurgitate, and with this regurgitation, the blood's going back and forth. It causes micro scratches in the endocardium of the heart. And these micro scratches allow for the bacteria to settle and thrive and cause vegetations. Basically, turbulent flow causing all of this. For, let's say, comes a patient with prosthetic mitral valve, and they're going to get a procedure done. Do you give them prophylaxis? Yes, you should, because they have foreign material in the heart. Have they previously been diagnosed and they're getting a procedure done? Been diagnosed with infective endocarditis and they're getting a procedure done? You should give them prophylaxis. Or people with cyanotic congenital heart diseases. Any patients undergoing high-risk procedures should be given prophylaxis. Any dental procedure, if it involves gingival, periapical region, oral mucosa procedure, any procedure that is done in an infective field, such as abscess, like a patient you're going to get, let's say, remove a tooth and the tooth is having abscess, it's best to give them prophylaxis. let's say you have a patient getting a dental x-ray, they're getting braces or anesthesia, you don't give them prophylaxis. Any bronchoscopy for lung cancer, you don't give them prophylaxis. Bronchoscopy for lung abscess, you give them prophylaxis because this is an infective field. So you need 2 criteria a patient must fulfill to receive a single dose of prophylaxis for infective endocarditis. It's either belonging to the high risk of infective endocarditis group, which we mentioned here, or is going to undergo high-risk procedure. So a patient with previous history of infective endocarditis undergoing dental x-ray, there's no need. Any prosthetic shunt undergoing tooth extraction. So patient with a prosthetic shunt is going under tooth extraction, you should give them prophylaxis for an infective endocarditis. The medications that you need to give for prophylaxis are either for patients with no allergy or for allergy. If patients have no allergy, it's amoxicillin, ampicillin, cefazolin, or ceftriaxone. For patients with allergy to penicillin or ampicillin, you give cephalexin, azithro or clarithromycins, doxycycline, and cefazolin and ceftriaxone. This is just you having to memorize the criteria and the medications, and you have to know the guidelines for it. So in case patient with this, so you can give the patient proper treatment. For empirical treatment, you still do not know which microorganism caused their infective endocarditis. So what you're going to think of is either patient with native valve or late prosthetic valve. You give them ampicillin, which is a cell wall inhibitor, gentamicin, which is an aminoglycoside, and ceftriaxone or flucloxacillin, okay? So this is, you have to knowing it. This is a summary for all of these parts that I wrote before. I'm just gonna give you the final summary, and it's very easy in case you don't have time to go over the lecture or just like as a summary just before the exam. In case of patient with early prosthetic valve, just think of prosthetic valve, you're gonna give rifampin. Rifampin is an RNA synthesis inhibitor. You're gonna give them as well gentamicin and vancomycin or daptomycin. So early PV, you're gonna give vanco or dap with genta and rifampin. Just rifampin is a very important one here. In case of patients with a native valve or late prosthetic valve with beta-lactam allergy, because you can't give them ampicillin and all of that, you're just gonna give them gentamicin with vancomycin. Vancomycin or cefazolin, whichever one works. So cefazolin / vanco plus gentamicin. For treatment of strep here. For native valve, let's say strep shows full susceptibility to penicillin, so we can give them penicillin. You give them penicillin G, amoxicillin, and ceftriaxone. Remember this as it can be either given alone or in combination. Remember this as the mnemonic pack. Penicillin G, amoxicillin, and ceftriaxone. To shorten the therapy, because in case of native valve, you give it for 4 weeks, and for 6 weeks, you give for 6 weeks in case of prosthetic valve. To shorten the therapy, you give them gentamicin. So PAC plus G for to shortening the therapy. Okay, it's shortening the therapy is only in cases of native valve endocarditis. Any allergy to beta-lactam, you give them vanco or daptomycin, whichever one. But it's just this medication. It's not a regimen for native valve streptococci or like allergy to beta-lactam allergy to beta-lactam for a patient with streptococci, penicillin-resistant microorganism. The treatment for streptococci, which is relatively resistant to penicillin, in native valve, you're also going to give them PAC, penicillin, amoxicillin, and ceftriaxone, or in combination with gentamicin for 2 weeks. So this is relatively similar. And for MSSA, or for staph. This is methicillin susceptible Staph aureus. This is S. aureus. Think of Staph aureus. We're not talking about streptococci anymore. We're talking about staphylococci. For staphylococci, you're going to give the patient for native valve flucloxacillin / cefazolin for 4 to 6 weeks, or in case of prosthetic valve, you're going to give them the same flucloxacillin and cefazolin, including rifampin and gentamicin. Rifampin is very important. You have to know when to give it, okay? For MRSA, you have native valve endocarditis or prosthetic valve endocarditis. For native valve, you just give them vancomycin. For prosthetic valve, give them vancomycin and rifampin plus genta. Rifampin, we memorized it as, or we remember it as prosthetic valve. So we think of prosthetic valve for MSSA or MRSA, or as empirical treatment in case of patient with early prosthetic valve infective endocarditis. This is the summary for what's mentioned previously. This is very easy lecture. All you need to know is you have to memorize these. You just know in what cases you're going to use which medication.